Hey, welcome back to the fourth part in a five-part lecture series. My name is Matthew Belzer. I'm your instructor, and today we're going to be going over hemostasis and blood clotting. As always, I've provided you with a set of learning objectives, and if you're in my class, I'd have the lecture handout either printed out or up digitally so you can take notes and answer questions as we go through the different slides. Now you'll notice on some of my slides you'll see a small speaker icon. If you miss the content and you just want to go back within your PowerPoint and play some of the relevant points to that particular slide, you can go back and do that on any slide that has a speaker icon. So hematopoiesis is the formation of formed elements that takes place in red bone marrow. Hematopoietic stem cells are found in red bone marrow, and remember, red bone marrow is found in spongy bone, which is all over the body. Now, when you think about these stem cells are capable of differentiating, meaning maturing into different types of cells, depending on the stimulus. So when blood oxygen levels drop, for example, that's detected by the kidneys. The kidneys release a hormone, a chemical messenger, directly into the blood. Some textbooks refer to EPO as being a cytokine factor. A cytokine factor is also a chemical messenger, right? Both a hormone and a cytokine are a chemical messenger, so don't get too confused between those. Both of them are chemical messengers. But they release EPO into the blood. EPO then travels to the distant target cells in the bone marrow, triggering the pathway of erythropoiesis, where we get the formation of a red blood cell. We discussed that in a previous lecture. Colony-stimulating factors, on the other hand, are released by white blood cells in response to infection, travel through the bloodstream, right? You could call them a hormone or a cytokine. Many textbooks refer to them as being cytokines, which are chemical signaling molecules. But they'll come, right? The colony-stimulating factors will trigger these stem cells to turn into the different types of white blood cells, depending on which specific colony-stimulating factor you're talking about. The final factor we're going to talk about is called thrombopoietin, or TPO. TPO. Thrombopoietin is produced by the liver, and it travels through the bloodstream to red bone marrow, where it binds to these hematopoietic stem cells, and it triggers the pathway of thrombopoiesis, the formation of platelets. So TPO triggers these stem cells to become these very large cells called megakaryocytes. Megakaryocytes are interesting for a variety of reasons, but you don't have to know a lot about them other than that they're gigantic cells that fragment, and those cell fragments are ultimately what produce platelets. Platelets last anywhere from 2 to 10 days or in humans, right? And so there are platelets. Now, when you think about thrombocytopenia, thrombocyte is a platelet. Penia means a reduced amount of, and we're going to talk about how medical language is structured in the next lecture. So it means a reduced number of platelets, and if you look down here on this image, you'll see here's a blood smear, and you can see those little cell fragments or platelets, and that's what a normal platelet count should look like. If there are no platelets, that's referred to as thrombocytopenia. And thrombocytopenia can actually cause excessive bleeding because you can't trigger that platelet plug formation that we're going to talk about in just a minute. And ultimately, then you can't activate your clotting pathway as effectively, so there's downstream consequences. Now, thrombocytopenia is often picked up on routine exams like a CBC, a complete blood count. And again, a platelet count should be between 150,000 and 450,000 platelets per milliliter or cubic centimeter of blood. If it's below 150,000, you are by definition thrombocytopenic. People who are thrombocytopenic for whatever reason tend to present with these little bruises, either these larger bruises called purpura or these small pinpoint hemorrhages referred to as petechia. So just keep that in mind, and that's thrombocytopenia. And there's a lot of different things that can cause thrombocytopenia. Infections that, particularly that impact the liver, like hepatitis, HIV, vitamin and nutrient deficiencies. So When you think about the importance of platelets, the most common cause of thrombocytopenia is actually medication induced. So when people are undergoing chemotherapy or radiation therapy to treat a particular cancer, remember that any cancer therapeutic, right, that we really have these days beside the more sophisticated ones, work by inhibiting the division of rapidly dividing cells. The cells in the red bone marrow, those hematopoietic stem cells, are rapidly dividing cells. So in addition to slowing the growth of cancers, chemotherapeutics like methotrexate also slow the division of those rapidly dividing cells in the red bone marrow. Unfortunately, that can lead to anemia. It can lead to leukopenia, a decrease in the number of white blood cells, and it can also lead to thrombocytopenia, right? So patients who are thrombocytopenic oftentimes need transfusions of platelets. So there's a technique essentially where you take blood out of somebody, you put it in a centrifuge that spins at a specific speed, and you extract just the platelets from their blood. It's called apheresis. Those platelets can then be used in cancer patients, right? That's the most common place where platelets are used. And trust me when I say these individuals are grateful, because that's a major problem. You want to be able to clot blood if you're going through something like chemotherapy, whereas a normal blood donation can only be distributed usually to one person. Donating platelets can actually impact like 12 to 18 patients. It's a very, very noble thing to do. It carries a big punch with respect to what you're actually doing and the number of people's lives you're impacting. So I've included a link down here to the Red Cross platelet donation website if you're ever interested in donating platelets. Now, when you think about a lot of blood clotting, right? A lot of the blood clotting pathways that we're going to talk about stem from activity in the liver. For example, thrombopoietin is produced in the liver. Your clotting factors are produced in the liver. So all of these things we're going to be talking about today, many of these proteins, notably thrombopoietin and the clotting factors we're going to talk about when we get into the clotting cascades, are produced in the liver. Therefore, any disease that impacts the liver is going to be problematic. So diseases such as hepatitis, diseases such as alcoholism or drug abuse, in which you're ingesting a substance that carries a disproportionate impact on the liver, right? Certain nutrient deficiencies or genetic disorders, anything that impacts the liver and damages the liver can lead to the formation of scar tissue in the liver. When the liver starts to become scarred up, scar tissue isn't functional liver tissue, right? So when the liver starts to get scarred up, the functions of the liver start to decrease. And the liver carries out, over 600 known functions. I say 500 in that recording, but there are now over 600 known functions of the liver. So the scarring of the liver is called cirrhosis. One of the huge impact cirrhosis of the liver has, for whatever reason, either you have hepatitis or you're an alcoholic or a drug user or a genetic disease that compromises the liver, whatever it is, right? If cirrhosis of the liver develops, blood clotting pathways become compromised, and that can lead to things like excessive bleeding. Excessive bleeding can be exceedingly dangerous. So when you think about hemostasis, heme means blood and stasis means slowing the flow. So the hemostatic pathways are pathways that slow the loss of blood. They are a series of responses that prevent blood loss. Now, when you look at blood flowing, here's a little GIF of blood flowing. We see a clot over here, but most of the blood and platelets aren't actually forming clots against that blood vessel wall. That's because the walls of blood vessels release a chemical signaling molecule called a prostacyclin. And prostacyclins that coat blood vessel walls essentially repel platelets. And in that repulsion of platelets, right, they prevent the formation of clots when you don't want clots to form. So those chemicals that coat the walls internally in blood vessels, these epithelial walls in blood vessels or endothelial walls in blood vessels, endothelium is simple squamous epithelium that lines blood vessels, right, are called prostacyclins, and they prevent the catching of things like platelets. They repel platelets and keep blood flowing smoothly, because you only want blood clots. We see a little blood clot over here when there has been damage to a blood vessel and blood loss is a threat. But you don't want clots to form inappropriately because that can cause its own set of problems. So hemostasis is just a series of responses that prevent blood loss, and they essentially work in a sequential fashion. They start with vascular spasm. Smooth muscle surrounding blood vessels that have been damaged constrict in order to slow the flow of blood into that region. Then we get platelet plug formation. Platelets stick together and start to aggregate. And then we get blood clot formation. So what we're going to do is we're going to go over each step of this hemostatic pathway one by one, and then we're going to draw a focus to blood clot formation because that tack on at the end is very, very important. So vascular spasm. When a blood vessel is damaged, the cells, right, that actually line that blood vessel get damaged as well, and in response to that damage they spill out different chemical factors that ultimately trigger, right, a localized response in which the smooth muscle tissue surrounding that blood vessel contracts. When that smooth muscle contracts, it narrows the diameter of the blood vessel, right, and it reduces the amount of blood loss. This is an immediate response to damage to a blood vessel. So this happens right off the bat when a blood vessel is damaged. Vascular spasm is really the only way that you can do things like survive getting your arm blown off, because those blood vessels just go and they cinch shut. If somebody is hemorrhaging from a blood vessel in one of their limbs or they got their arm blown off, you would apply what's called a tourniquet. You could use like a belt or a rope or whatever it is, and you always do, there's a rule with tourniquet application, it's called high and tight, right? You put it as far up on the limb as you can and you rah! Because you're trying to simulate vascular spasm. Vascular spasm is what allows time for things like platelet plug and blood clots to happen. So that happens immediately. You want vascular spasm to kick in lickety-split. The second step is what's called platelet plug formation. So platelets are floating through the system, and they will bind, like when a blood vessel is damaged, you get things like collagen fibers dangling out. And platelets will actually latch on to collagen fibers. And when they latch on to collagen fibers, they start to release things like platelet factors. Platelet factors are just chemical signaling molecules called paracrine factors that work locally, and they're going to activate more platelets. They're going to make that platelet more sticky, and they're going to activate more platelets. So the stimulus here is a platelet sticking to a collagen fiber. Platelets start to release platelet factors. Platelet factors include things like thromboxane A2, serotonin, adenosine diphosphate, right? They spill these out into the system, and those platelet factors ultimately activate more platelets. And in response, when one platelet sticks, more platelets stick, and then more platelets stick, and then more platelets stick until a platelet plug is formed. It leads to a positive feedback pathway. Remember, childbirth and blood clotting are our two positive feedback pathways. So you think stimulus, platelet binds to a collagen fiber, right? It functions like the receptor in the control center. It releases its effector, which is platelet factors. Platelet factors make the platelet more sticky, and the response is even more platelet sticking until the loss of blood has stopped or you die. Remember, hemostatic pathways kick in, positive feedback pathways kick in when you absolutely positively need to get something done when there is an imminent threat to homeostasis. So if you think about medications, you'd never associate, for example, selective serotonin reuptake inhibitors to treat conditions such as depression with the blood or having any hematological effects. But everything is connected because these platelets use serotonin as one of their platelet factors. Things like SSRI medications can actually interfere with platelet pathways and make people susceptible to things like bleeding. Then you get the factors attracting more platelets. Platelets also release factors called procoagulation factors. Procoagulation factors are ultimately going to activate those blood clotting responses that we're going to talk about in the next few slides. They also release factors that are called tissue factors or healing factors that are going to initiate the process of tissue healing. They're going to trigger these cells, for example, to undergo mitosis, to start dividing so they can replace the scar tissue that formed, etc. So platelet plug formation happens, and then we get what are called blood clotting pathways. So there are two different blood clotting pathways. There's the intrinsic pathway. Now, I want to make a point here about the intrinsic and the extrinsic pathways before we look at each one independently. So you get vascular spasm, platelet plug formation, but now you need a blood clot to form. Platelet plug and blood clot is different. It's a different process. Blood clots form via either the intrinsic pathway. The intrinsic pathway only activates. So the intrinsic pathway only activates when there is internal damage to a blood vessel, such as an exposed collagen fiber. So when there's internal damage to a blood vessel. How do blood vessels get damaged internally? Well, conditions like hypertension. High blood pressure can actually put stress on blood vessel walls, and it can tear the internal portion of blood vessel walls apart if you have high blood pressure, especially for a prolonged period of time, and that can make these intrinsic pathways likely to activate in order to prevent these little microbleeds that could occur all over the place, right? So high blood pressure can damage blood vessel walls internally. There can be all sorts of things, inflammatory factors and excessive cholesterol, all sorts of things. But this activates in response to internal damage. The extrinsic pathway is when a blood vessel, which is the more important of the two pathways in my estimation, is when a blood vessel has been damaged externally. Like you have a cut and you've actually cut through the blood vessel wall, right? That's when the extrinsic pathway is activated. Now, both of these pathways lead to what's called the common pathway, but they do it in a slightly different way. So when the intrinsic pathway is activated, you get collagen or other activators. So what you're thinking about here is collagen is dangling out, platelet binds, and the platelet releases platelet factors, more platelets stick, and then the platelets release what are called clotting factor, or procoagulation factors. So those platelets release procoagulation factors, and it's those procoagulation factors that function as activators for the intrinsic pathway. Now, all of these Roman numerals you see right here, right, are what are called clotting factors. The overwhelming majority of clotting factors are proteins that are synthesized by the liver. And remember, with any proteins, where do they come from? Well, you have DNA. Functional units of DNA are called genes. Through the process of transcription, DNA is used to make mRNA. Through the process of translation, mRNA is used to make a protein. And that protein goes out and serves a function. The clotting factors, such as clotting factor 12, clotting factor 11, clotting factor 9, clotting factor 8, and clotting factor 10, etc., all those clotting factors, they serve the function of ultimately leading to a pathway that will produce a blood clot. A couple of things that I want to highlight about signaling cascades. Remember that amplification occurs at each step. So these activate more, so you get a massive response very quickly, right? That's one of the things I want to highlight. The other is that we use often Roman numerals, although on a short answer question, if you didn't use Roman numerals, I wouldn't get too bent out of shape. Another thing I want to highlight is that calcium functions as what's called a cofactor, and calcium is often necessary to convert inactive forms of clotting factors into active forms. So calcium plays a really, really important role in blood clotting. So we have the intrinsic pathway, essentially internal damage to a blood vessel wall leads to collagen fibers being exposed, platelets latch, they release procoagulation factors. Those factors activate clotting factor 12, so it converts clotting factor 12 into active clotting factor 12, which then converts clotting factor 9 into active clotting factor, clotting factor 11 into active clotting factor 11, clotting factor 9 into active clotting factor 9. Clotting factor 9 activates clotting factor 8. Clotting factor 8 then converts clotting factor 10 into active clotting factor 10. This is the common pathway right here, right? Meaning that both the intrinsic and extrinsic pathways will act on this pathway. The extrinsic pathway, on the other hand, works by if a blood vessel is damaged, clotting factor 3 is released. Clotting factor 3 forms a complex with clotting factor 7 and calcium, right? They essentially clump together to form this big protein complex that will ultimately activate clotting factor 10. This one's really important because if you damage a blood vessel wall externally, you really need to stymie that blood flow. So now we're going to look at the intrinsic and extrinsic pathways individually. So remember, the intrinsic pathway activates when you have damage internally to a blood vessel. So you have damage internally to a blood vessel. What can cause that damage? Things like high blood pressure can put stress on the blood vessel wall, and it can essentially fray the lining of the blood vessel wall and expose collagen fibers. When collagen fibers are exposed, platelets will catch. They will undergo the platelet plug formation, right, through the release of platelet factors. They'll also release procoagulation factors, which then activate the proteins of the clotting cascade. The first protein in the intrinsic pathway to go from being inactive to active is clotting factor 12. Clotting factor 12 is also called Hageman factor. Again, it's a protein synthesized by the liver that plays a role in this clotting cascade. Interestingly enough, because the intrinsic pathway activates in response to internal damage, this tends to be the one that's most closely associated with problems such as the development of things like deep vein thrombosis or blood clots, right? And blood clots can be really problematic because they can cause problems all over the place. And we'll talk a little bit about the problems that blood clots cause in just a moment. So Hageman factor, you would think that people who had a genetic disease that influenced Hageman factor would have a susceptibility to increased bleeding, and they do, right? They have a prolonged what's called prothrombin time, or they have a long clotting time, like if you're just measuring clotting time from like a finger stick. But one of the interesting things is that people who have this genetic disorder in which they're not producing very much Hageman factor tend to have lower risks of developing blood clots that can lead to things like heart attacks, or blood clots that can lead to things like strokes. So there's been a lot of interest in this as a genetic therapy or what's called a drug target with respect to treating things like DVT or preventative measures for things like DVT. So activated clotting factor 12 activates clotting factor 11. Clotting factor 11 is called antihemophilic factor C. Any mutation to the gene that produces clotting factor 11 leads to what's called hemophilia C. Hemophilia C is a relatively rare disease. It's often caught when people do things like they undergo something like a dental surgery and they have excessive bleeding in their mouth. Or when women have hemophilia C, they can present with things like particularly heavy menstrual flow with a lot of blood. And hemophilia C, when you think about treating it, you can treat with the actual factor itself, which we're going to talk about in just a moment. You also want to maintain really good dentition and take care of your cardiovascular health because you don't want to put pressure or stress on those blood vessels that could cause bleeding. And a lot of times, women with hemophilia, any types of the hemophilia, who have particularly heavy menstrual flows will be put on hormonal contraceptives because hormones can influence these clotting pathways. That's why hormonal therapies actually carry a risk of increased blood clot formation or the increased risk of blood clot formation in the body because they influence that. It also, taking birth control, if you do it in a certain way, will prevent periods from happening. So it just prevents that particular process altogether. So you get clotting factor 11, which activates clotting factor 9. Clotting factor 9 is called antihemophilic factor B. It's linked to hemophilia B, which is an X-linked disorder. This is a trait that tends to be passed down from mother to son that actually express this trait. It's a recessive trait. And again, like many types of hemophilia, it's associated with excessive bleeding in response to damage to the tissue. So, you got to take care of your dentition. You got to be careful about certain types of bleeds. One of the important things with hemophilia C, you don't tend to see bleeds into the skeletal muscles or into the joints. With hemophilia B and A, you do get bleeds into things like skeletal muscles, joints, the kidneys, and that can be really problematic. So these tend to manifest more severely. So you get clotting factor 9, which activates clotting factor 8, which is also called antihemophilic factor A. Hemophilia A, which is what we think of as being classic hemophilia, is also X-linked and carries all of those different things. So sometimes hemophilia is caught, for example, with men during the circumcision when babies are born. Even, you'll see this excessive blood loss. Things like small cuts producing massive blood loss, dental procedures, etc. Extended, long what are called prothrombin times, which we're going to talk about, long clotting times with that stick on the finger. So again, when you think about how hemophilia A and hemophilia B are treated, now that we have things like recombinant DNA technologies, we can actually use bacteria as little factories for proteins, right? And we can produce these clotting factors, these proteins, and we can inject them into the body, and they last for a certain period of time. But because you need a lot of them, and there needs to be kind of a constant flow because these proteins degrade, a lot of people with hemophilia will get what's called a port put in, and that port will be linked to a major blood vessel. So it's a little bit, it makes it easier to administer that medication that you need so frequently in such large quantities. So if you see somebody with a port, they could be hemophilic, right? Now, activated clotting factor 8 activates clotting factor 10. Clotting factor 10 is also called thrombokinase. Thrombokinase, remember what kinases do. They pin phosphate groups to other proteins, activating other proteins. So this is like an on switch that converts prothrombin to thrombin, which is really, really important. Now we're in the common pathway. Both the intrinsic and extrinsic pathway lead to the activation of clotting factor 10. So clotting factor 10, which is synthesized in the liver, needs vitamin K. Vitamin K is a fat-soluble vitamin. It serves a variety of functional roles. One of the most important is that you need vitamin K as what's called a coenzyme to synthesize clotting factor 10. If you have a vitamin K deficiency for whatever reasons, you can't activate or synthesize clotting factor 10. If you can't synthesize clotting factor 10, that can lead to serious bleeding problems. And then after clotting factor 10 is activated, you have the common pathway, that downstream end of the pathway, in which the extrinsic and intrinsic pathways merge with one another. Now in the extrinsic pathway, remember, the extrinsic pathway is triggered by damage externally to a tissue. When tissues are damaged within the actual cells of the tissue themselves, they have something called tissue factor, right? Tissue factor is also called clotting factor 3 or thromboplastin. So cells get damaged, tissue factor, aka clotting factor 3, is released. Clotting factor 3 binds to clotting factor 7 and calcium to form activated clotting factor 7. Clotting factor 7 is also called proconvertin. So there are diseases, if you have a genetic disease that impacts the formation of clotting factor 7, right, you can get what's called hyperconvertinemia. And essentially what happens here is clotting factor 7 can't activate clotting factor 10, and it presents like all of the other clotting factor problems with excessive bleeding. Can bleed into things like muscles, joints, you can urinate out blood. If you have damage from, an external cut or something, it can be a particularly heavy bleed. So think back to everything we've talked about before. So clotting factor 7 then activates clotting factor 10, and now we're in the common pathway. If you have genetic deficits or defects of clotting factor 10, that leads to something called Stewart-Prower syndrome. Again, any disease that has to do with the clotting factor is going to lead to things like excessive bleeding, right? If you're getting a surgery or something like that, you're going to see excessive bleeding. You've got to take care of your dentition or any tissues that are prone to bleeds, etc. Now, with the common pathway, what we're talking about is down here. So you get the intrinsic pathway, which is activated due to internal damage of a blood vessel. The external pathway, which is activated due to external damage, leads ultimately to the common pathway. Activated clotting factor 10 converts prothrombin into thrombin. So it converts prothrombin into thrombin. Thrombin then converts soluble fibrinogen. So fibrinogen is soluble, it's floating around in the blood, you can't see it. But when thrombin converts or cleaves a little bit off the fibrinogen molecule, it converts it into insoluble fibrin. And insoluble fibrin, right, in conjunction with clotting factor 13, creates these little mesh nets around blood clots, around platelet plugs and blood clots that catch all of those formed elements kind of running through and forms traditionally what we think of as being a blood clot. So when you think about blood clotting time, there's a really common test that's run on blood to evaluate somebody's clotting health or their hemostatic health, right? Can they form a blood clot? Can they prevent blood loss? Might they have a genetic disease like hemophilia or Stewart-Prower syndrome or something like that? And it's called prothrombin time. So essentially you take blood, right? And you centrifuge it to separate out the plasma. You then get that plasma, you throw in some calcium and some thromboplastin, right, because you need calcium to activate those pathways, to activate those clotting factors, and then you look to see if you get a clot in the plasma, right? You can actually see it convert because those pathways will activate and you can actually see it convert, and you measure it in seconds. So when I say prolonged prothrombin time, what I'm saying is it takes longer to form a blood clot. So when you think about what can cause prolonged prothrombin times, anticoagulants, medications used to treat things like blood clot formation, decreased synthesis of clotting factors due to things like genetic disease, liver diseases, vitamin K deficiencies, right? So there are all sorts of things that can cause an increase in prothrombin time, but you're just separating out that plasma and you're looking for the amount of time it takes to form a clot, right? It's measured in seconds, and you look at the reference range, and if the prothrombin time exceeds that reference range, it means that person has trouble forming a blood clot, and that can lead to some very important kind of revelations about that patient's health. Is it hemophilia? Do they have a liver disease, right? We need to be careful. They'll always do this before surgery, just to make sure that that patient is going to be able to survive a surgery, because you don't want excessive bleeding during a surgery. So when we think about the common pathway, you get clotting factor 10, which converts prothrombin to thrombin. Thrombin then converts fibrinogen into fibrin, which are these insoluble fibers that essentially form nets. And this conversion, you need clotting factor 13. But they essentially form these insoluble nets, and these nets catch all these, fragments and blood cells, etc., running through, and they form what you traditionally think of as being a blood clot. So when you're looking here, remember that the walls of blood vessels are lined with prostacyclins, and prostacyclins prevent the latching on of platelets. They repel platelets, essentially, to make sure that blood flow is moving through the vessel smoothly. Now, let's say you have damage to the blood vessel wall. What do you think this would be? An internal or intrinsic or extrinsic pathway? It's probably an intrinsic pathway that you see here. So you have collagen fibers, right? Platelets bind, they start releasing platelet factors. More platelets stick, they start releasing procoagulation factors. Clotting factor 12 goes from inactive to active. Clotting factor 12 activates clotting factor 11. Clotting factor 11 activates clotting factor 9. Clotting factor 9 activates clotting factor 8. Amplification at every step along the way. Clotting factor 8 activates clotting factor 10. Clotting factor 10 converts prothrombin to thrombin. Thrombin converts fibrinogen to insoluble fibrin. Those little things you're looking at right there that almost look like a net that caught these blood cells, those are fibrin proteins. So when you're looking at this blood clot here under an electron microscope, this is what I mean by insoluble fibers that form a net, allowing for the blood vessel to blood clot to occur in the first place. This is fibrinogen, soluble, gets activated, becomes insoluble, forms nets that trap all these formed elements and prevent the further loss of blood. Fibrinogen is also synthesized in the liver, right? So fibrinogen, which is absolutely necessary because it's the final step of a blood clot, it's necessary to form a blood clot, is also synthesized in the liver. The liver plays a hugely important role in the clotting of blood. So if a blood clot forms, remember that you have all of the platelets have activated healing pathways, and that blood clot is going to start remodeling, and you're going to want to heal that tissue. So just like you need to form a blood clot, you also need to break a blood clot. And what happens is you have another enzyme that's in its inactive form called plasminogen. And when a blood clot needs to be broken down, there is a factor called tissue plasminogen activator that converts plasminogen into active plasmin. And what plasmin does is it breaks down fibrin. So essentially plasmin comes in and it starts literally breaking down all of this fibrin, and all of those trapped formed elements can be released, right? So you get the release of all that stuff. So you break down, you start actually physically breaking down that blood clot, and that's what TPA does. It activates plasminogen to form plasmin, and then plasmin breaks the fibrin polymers into fragments that can be swept up through the bloodstream. You want to form a clot at sometimes, and you want to break that clot down when it's no longer needed, right? That's called fibrinolysis. The breakdown of fibrin, right, into fibrin fragments is called fibrinolysis. So you need this tissue plasminogen activator to activate plasminogen to form active plasmin, which breaks down fibrin into fibrin fragments. Now, when you think about blood thinners or anticoagulants, first, again, I have to highlight, don't confuse agglutination and coagulation. Coagulation is the result of blood clumping as a result of blood clotting pathways and the activation of clotting proteins. Agglutination is the clumping of red blood cells as a consequence of antibodies binding. Two different processes. Now, there are many different anticoagulants. Heparin is a very common one. We use heparin all the time. Heparin prevents the formation and activation of a constellation of clotting factors. That's what heparin does. It works on the clotting factors. Aspirin, on the other hand, you've probably heard of aspirin therapy for people who are at increased risk of things like heart attack or stroke, right? Aspirin inhibits the activity of what are called COX enzymes, and COX enzymes are necessary for the activation of platelets, so they prevent the formation of platelet plugs. Warfarin and Coumadin prevent the activity of vitamin K, right? So all of these different anticoagulants work via a specific way, but they all work to one goal. A blood clot forming when it's not supposed to is problematic. Now, what tends to be the more problematic from a clinical perspective with respect to the different pathways is the intrinsic pathway, because it reacts to internal damage in a blood vessel. Things like high blood pressure or plaques forming on the wall of blood vessels, etc., can damage blood vessel walls. And if a blood vessel wall is damaged, you can start getting the formation of blood clots, right? Blood clots can form in these blood vessels. Now, if these blood clots are big enough, they can block blood vessels up, so they can actually form and they can block a blood vessel. If a clot is big enough to block a blood vessel, it's going to prevent the flow of blood to anything downstream of that blood vessel, meaning all of that tissue downstream will no longer be getting blood, and it will become oxygen deprived, CO2 rich, metabolic toxin rich, and that tissue will begin to die, which will put a lot of stress on the tissue. So if a blood clot forms inappropriately, which often happens, it's a major problem in medicine, it can lead to things like a myocardial infarction, right? Blood clot forms, you can't get blood to the heart, stresses the heart, leads to a heart attack, you die. You can get things like strokes, blood clot forms and blood vessel feeding into the brain. Brain doesn't get oxygen and nutrients. The tissue begins to die, which can lead to very serious problems. You get blood clots forming, along the GI tract, which can kill entire segments of your small intestines that, if not surgically removed, you'll die. You can get blood clots leading to limbs, which can, lead to limb amputation. So anticoagulants are pretty important. For the treatment of an acute blood clot that you just have to clear up, like let's say a clot that's preventing blood flowing to the heart, you use what are called thrombus or clot busters. And the most common clot buster that's used is what's called tissue plasminogen activator. So when you pump in tissue plasminogen activator, it activates plasminogen and causes it or converts it to active plasmin, which then breaks down the fibrin fragments, that these networks that actually hold a clot together, and it breaks the clot, right? And if you're trying to get blood flow reestablished back to the heart, that's important. You need to bust that clot up. One of the problems with using tissue plasminogen activator is that clot busts into smaller clots, and then those smaller clots can run all over the body and maybe clog up something in the lungs, leading to a pulmonary embolism or a downstream stroke or whatever. So there are problems, right? You can't influence one pathway without subsequently influencing another. Now, we talked about hemophilia, and each of the hemophilias ultimately stem from a genetic mutation that produces one of your clotting proteins. If that doesn't happen, you get excessive bleeding, and it's problematic. Now, the final thing I may ask you about is how liver damage can ultimately lead to problems with blood clotting pathways, and you're probably aware of a lot of what I'm going to talk about. So there are a lot of things that can damage the liver. Hepatitis, HIV, heavy metal toxicities, the pharmaceutical medications that are particularly hard on the liver. But one of the most common reasons for damage to the liver is ethanol, which is the type of alcohol we drink. Because ethanol is processed in the liver, ethanol actually puts a lot of metabolic stress on the liver. If you're constantly putting metabolic stress on the liver, those liver cells can start to die, and what will replace those liver cells are scar tissue. And when scar tissue starts replacing healthy, functioning liver tissue, it can lead to a condition called cirrhosis of the liver. So alcoholics tend to be bleeders, right? And I've worked with a few in my day in an emergency setting. We had a homeless guy fall down the stairs one time, and we just could not stop this bleed. But anyway, so why do alcoholics have this tendency to bleed excessively? Or why does anybody with liver damage have the tendency to bleed excessively? Well, if you have liver damage, the liver's not going to be synthesizing as much thrombopoietin or TPO. No thrombopoietin, no thrombopoiesis, meaning no formation of platelets, no platelet plug formation, no blood clot, leads to thrombocytopenia. Thrombocytopenia, can't form the platelet plug, can't form the blood clot, you're going to get excessive bleeding. Most of the clotting factors are synthesized by the liver. If the liver is damaged, it's not going to be synthesizing those clotting factors. If those clotting factors aren't synthesized, that's going to impact both the intrinsic and extrinsic pathway. When those are compromised, you're going to get excessive bleeding. Alcoholics tend to be vitamin and nutrient depleted. So when you're drinking excessive amounts of alcohol, what you do, literally, in a very literal sense, is you just urinate out all the key vitamins and minerals. Alcoholics, by the time they get to long-term rehab facilities, have to go on some pretty intense vitamin cocktails just to bring their levels back up to reference range. Vitamins that are hit particularly hard are things like vitamin K and the B vitamins. So if vitamin K levels become depleted as a consequence of essentially just rinsing that stuff out of your body, vitamin K is necessary for the synthesis of a number of clotting factors, clotting factor 10 being the most important there. Clotting factor 10, no activation of the common pathway, you're going to bleed, right? No activation of the clotting pathway, you are going to bleed. Finally, the liver is responsible for the synthesis of fibrinogen, and fibrinogen is converted to fibrin, which forms those nets, which actually forms blood clots. It's the most important part of the clotting pathway, in my opinion, right? So if you don't have fibrinogen, you don't actually form the net of a clot, because when fibrinogen is activated to fibrin, it forms these nets. No fibrinogen, no fibrin, no nets, no blood clot, right? So the liver also synthesizes fibrinogen. No fibrinogen, problematic. You're going to bleed a lot. So there's a quadruple whammy on people with liver damage with respect to their blood clotting pathways. In fact, surgeons will often run 2 tests prior to performing surgery. One of them is the one that we just talked about, which is the prothrombin time, just to look to see whether a fibrin clot is forming or not. The other is just looking at the levels of fibrinogen in the blood, right? And think about all those questions I've been giving you with respect to reference ranges and patient value. You don't have to know the level. If fibrinogen levels are low, that person is going to be prone to bleeding, right? It could also be indicative of a liver problem. So could the absence of clotting factors, right? The absence of TPO. All of those things revolve around the liver in some way, shape, or form. It's very, very important. So that's it. Have a good day.